According to the New York Times, cataract surgery may prolong your life. In reality, cataract surgery is the heart and soul of ophthalmology, and some consider it to be a miracle of the 20th century medicine. The purpose of this presentation is to show its amazing evolution from ancient times to the present. This small statue with a white cataract in the left eye is considered to be the oldest documented case of cataract history. It dates back 4,500 years, and it is exposed in the Egyptian Museum in Cairo. In the preparation for this talk, I thought it would be interesting to visit this museum. So as soon as I got to the magnificent museum, I immediately headed for the statue's room. To my surprise and disappointment, I noticed that the white cataract of the famous statue had been removed. This event, to some extent, symbolized the remarkable expansion in indications for lens extraction. Nowadays, about 25 million lens extractions are done worldwide every year. The most ancient cataract surgical procedure was named couching and had its origin in India in the 6th century before Christ. It consists of intentional displacement of cataract into the vitreous space. This primitive technique was performed along many centuries and was introduced in North Africa during the time of Alexander the Great. It is worth mentioning that in the region of the city of Thebes, today Luxor, by the Nile River is located the famous Valley of the Kings, where splendid pharaoh tombs were built next to this mountain range. By looking at some tombs' walls paintings, we might assume that Egyptians were familiar with couching at that time. In this beautiful archaeological site, we find well-preserved 4,000-year-old mummies with its mummification instruments. Some of them have something in common with the ones used for couching in India, like this one which is on display at the Museum of the Royal College of Ophthalmologists in London under the direction of Mr. Richard Keeler. This award-winning film shows how couching was done in Nigeria just before the turn of the last century. Under topical anesthesia, a sharp, fine instrument penetrated into the eye in the region of the pars plana, and after breaking the zonules, the opaque lens was dislocated into the vitreous cavity, thus restoring some limited, unfocused vision. At the Museum of the History of Medicine of the University of Ghent in Belgium, under the direction of Professor Jean-Jacques Delay, we can see well-manufactured couching needles of the Gallo-Roman period, that is, the first centuries of the last millennium. Even monks in medieval Europe used these instruments for couching. Some centuries later, couching was still the only surgical treatment for cataract. It is important to point out that at this time, there were neither anesthesia nor electrical light, so couching was performed at daytime with the patient seated in this embarrassing position, facing the window, and the surgeon seated at a higher level. The assistant stood behind the patient to hold and immobilize his head. We might wonder, has this surgery ever been performed in Brazil? Most likely yes, considering that this Brazilian doctor defended a thesis about couching in Germany in 1844 and then moved back to the hinterland of Brazil. History does not forgive this controversial doctor from England, John Taylor. He was an itinerant couching surgeon, but above all, an expert in self-promotion. In one of his trips, he stopped in Leipzig and operated on both eyes of the famous composer Johann Sebastian Bach in 1750, and the outcome was catastrophic to the point that he passed away a few months afterwards due to unhappy consequences of a very unsuccessful cataract operation. Without any doubt, the greatest hero of this time was the French surgeon Jacques Daviel, who introduced the extraction of cataract through an inferior limbus incision. And here we see the well-kept original instruments used by Daviel over 250 years ago. Another instrument used by famous surgeons who succeeded him. It is worth mentioning that anesthesia did not exist at that time, only a century later. Daviel had a very interesting life, and these two institutions in Paris hold a great deal of old books about his new technique to treat cataracts, related publications, and original manuscripts of his time. Daviel became very famous and worked as an ophthalmologist for the court of King Louis XV. He died in Geneva and is buried there. His epitaph in Latin means, "After darkness, light." Well deserved. He became a household name all over France. Streets and squares were named after him. Here we see a stamp celebrating his third centennial of his birth anniversary. Daviel was born in a small city in Normandy, where we find a statue with the following saying: "To Jacques Daviel, inventor of cataract extraction, with the recognition of your homeland and mankind." Interestingly enough, on the other side of the base of the statue we can read, "This statue, inaugurated in July 1951, replaces the one that was taken away by the Germans in 1942, that is, during the Nazi occupation in this era in World War II. The original statue, made out of bronze, most likely was melted for bellicose purposes." Speaking of Germans, we must never forget to acknowledge the important contributions of von Graefe to ophthalmology. In 1865, he introduced his technique of cataract extraction using a superior limbus incision. His knife was immediately adopted by many surgeons, evolving into different models. On the right, we see the classic von Graeff's knife next to a current disposable 2.2 cornel knife. Very seldom we do come across surgical instruments that were used over 100 years like von Graeff's knife. It is worth mentioning that topical anesthesia was introduced a few decades later, so these knives, like the von Graeff's one, had to be very sharp to be efficient and more easily tolerated by the patient. Mr. Richard Keeler, curator of the Museum of the Royal College of Ophthalmology in London, explained how the sharpness of von Graeff's knife was gauged.
Explain, yeah.
The way you could find out whether the point was sharp or not was with this kid skin under tension in this little drum, and it would be offered up without gripping hold of it to the drum, and if it penetrated the skin, you knew that it was sharp, like that. If it wouldn't go into the skin, then it was blunt. So that means it's and then some of them were beautiful little boxwood, made of boxwood. Same thing with their own little box to take it around with.
And here we see von Graeff's knife in action almost a century later after its invention in a blocked patient. Von Graefe has won public acclaim in Germany for his contributions to ophthalmology. This impressive monument in Berlin is an example of it. And also this stamp celebrating his 150th birth anniversary in West and East Germany in 1978. The introduction of cocaine as a topical anesthetic by Karl Kohler from Vienna, a friend and contemporary of Freud, was a major breakthrough for cataract surgery. In Freud's former office in Vienna, today a museum where we are able to get information about this important discovery. It is interesting to point out that intracapsular and extracapsular techniques appeared nearly at the same time in mid-18th century, but the intracapsular approach took longer to gain popularity due to its high incidence of complications like vitreous loss and postoperative infection. Samuel Sharp from England was a pioneer in this technique. The action that took place at the bottom of an aquarium, that is, fish transporting tiny pebbles with their mouth from one place to another, inspired the Catalan eye surgeon Ignacio Barraquer to develop his intracapsular technique using an ingenious device called Rizofake in the beginning of the 20th century. Nifty manual devices came out, like these ones. Their
Okay,
mechanism of action
this
is
is an
explained by
Rizofake.
Mr. Richard
The
Keeling.
little end is a concave receptacle to place on a lens, and this is the suction method. So when that's depressed, it will form a negative pressure, and then the lens actually will adhere to the little cup. So that's how it was done.
And here we have an intracapsular extraction surgery done over a century ago. Amazing, a century ago. The cameraman had to be as skillful as the surgeon, lying down on this narrow platform above the patient, holding his heavy camera to record the surgery. A really risky business. Here's the assemblage of the vacuum device. Surgery was done under topical anesthesia using this indefectible Graefe's knife and vacuum technique for the intracapsular extraction of the cataract. Von Graefe's knife, the vacuum instrument, and the lens is out. At this time, there were no sutures. This is the son of Ignacio Barraquer, Joaquim Barraquer, who introduced the use of alpha-chymotrypsin to dissolve the zonules, thus facilitating the intracapsular extraction of the cataract. And here we see another way to do intracapsular cataract extraction in the 50s, using a capsule forceps to remove the cataract. And a few years later, cryoextraction of the cataract was introduced by Krawiecz from Poland. This technique prevailed during the 60s and the 70s. This video clip shows how cataract surgery was performed during my residency years in mid-70s. After creating a very wide limbus incision, the cryoprobe was activated and immediately became attached to the lens. Then, using side-to-side movements, the zones were broken and the cataract was finally removed from the eye, and a few sutures at that time. We closed the incision with sutures. Here we see steps of cryoextraction with its dire consequence, aphakia. The first cryoprobes were used for both cataract and retinal detachment surgeries. In the beginning, the cryoprobe was of considerable size with different tips. As you can see here, the long tip. And with the help of this funnel, liquid nitrogen was deposited inside the large handle. And that was how it was done. 1960s. The nitrogen cryosets got smaller over time, and some of them as small as a pen and disposable. And here we have a set of instruments used for intracapsular cataract extraction in the 70s. Without any doubt, the two great names in cataract surgery of the 20th century were Harold Ridley, pioneer intraocular lenses, and Charles Kelman, inventor of phacoemulsification. And they have something in common in their lives. In the beginning, both were severely criticized, especially by some members of the academic elite, like the renowned Professor Duke Elder, who bitterly disapproved Ridley's invention. Interestingly enough, they were neighbors on the exclusive Harley Street in London. Duke Elder lived and worked at 63 Harley Street, and Ridley 4 buildings down at the number 53. Imagine the energy of this neighborhood at this time. Fortunately, both Ridley and Kelman had the joy and pleasure to receive the highest honor of their countries, and brought forth this thriving industry of IOLs and phaco machines. For those interested in the subject, I strongly recommend reading Kelman's autobiography, Through My Eyes, and the biography of Ridley written by David Apple. The events that happened in the skies of this beautiful white cliffs region in the south of England in the summer of 1940 was crucial to the development of intraocular lenses. This is where the well-known Battle of Britain took place between the British and the Nazi air forces in the beginning of World War II. Hurricanes and Spitfires were the Royal Air Force planes which fought this battle. Their cockpit canopies were covered by a transparent acrylic similar to PMMA. Ridley observed in some pilots who had their cockpit canopies shattered, small fragments of this plastic lodged inside their eyes without triggering relevant inflammatory reaction. Ridley recognized that this acrylic could be used to manufacture an intraocular lens to be implanted into the eye to replace the natural lens removed during cataract surgery. And here we see a replica of the first intraocular lens made of the same material of the cockpit canopy of those planes. The shape and dimensions of the artificial lens simulated those of the crystalline lens. It is worth mentioning that it took a period of 9 years to materialize Ridley's project. Many colleagues showed no enthusiasm for his project, including Ridley's own father, who was also an ophthalmologist. And here we see one of the first surgeries with implantation of the intraocular lens after an old-fashioned extracapsular cataract extraction with a very large incision done by Harold Ridley at St. Thomas Hospital in London. And that's the end of the surgery. Very thick sutures. At this time, eye surgeons used magnifying glasses to perform cataract surgery, as motorized zoom microscopes were only introduced in ophthalmology in the 60s. And here we have the famous St. Thomas Hospital, situated on the south bank of the Thames, facing the British Parliament and the Big Ben, beautifully located. And now we're walking inside St. Thomas Hospital, where Ridley pioneered intraocular lens implantation and where he himself underwent successful cataract surgery with IOL implantation in both eyes in the 90s. So the inventor benefited from his own invention. This plaque honors Ridley's groundbreaking achievement. The real first IOL implantation was done on November 29, 1949, but Ridley did not leave the implant inside the eye. Less than 3 months later, he did a secondary implantation on the same patient, leaving for the first time an IOL inside an eye. Interestingly enough, this procedure was coined lenticular graft. This is the gorgeous view of the British Parliament from the St. Thomas Hospital at dusk. In 1903, exactly at the same location and angle, the famous French Impressionist artist Claude Monet did this beautiful painting named Houses of Parliament at Sunset, which is displayed at the National Gallery of Art in Washington, D.C. A few years later, the artist started complaining of color changes because of cataract. At that time, the reputation of cataract surgery was not very good, so he put it off as much as he could until he decided to face it in 1923. Monet returned to France, where he underwent an eventful extracapsular cataract extraction in his right eye. Here we see the glasses prescribed to him after surgery, but the outcome was very disappointing. Here we see a very glum remark written by Claude Monet. Aphakia was truly a major complication after cataract extraction. The cure of aphakia should always be celebrated. This is Ridley's original publication on IOL presented for the first time in Oxford Congress in 1951, being coldly received by the overwhelming majority of his colleagues with a great deal of criticism. Time has corrected that, and in the end, Ridley was able to savor his very successful mission. The extracapsular technique was practiced during many years and preceded phacoemulsification. We have to pay homage to McIntyre and Simcoe from USA and Blumenthal from Israel, whose manual techniques using simple devices made possible to do this procedure with efficiency, safety, and at a low cost. The extracapsular technique is still used, especially in cases of black cataract or cataract nigra, as shown here. Here we see the extraction of a super black cataract, and then the implantation of an intraocular lens. Phacoemulsification was introduced by Kellman in 1967 and changed cataract surgery radically. It was truly a revolution. And here we see the first phaco machine and its heavy hand piece. Kellman performed first surgeries under great secrecy at Manhattan Eye and Ear in New York City. The first phacoemulsification took 76 minutes to be done. It is important to point out that the procedures were carried out in the anterior segment, in the anterior chamber. There was no viscoelastic at that time, and the machines had no surge control. You can only imagine the complications. Phacoemulsification took many years to consolidate as a safe and efficient procedure. I was a fellow at Manhattan Eye and Ear in 1982 and was able to notice that extracapsular was still the prevailing cataract extraction technique there at that time. I had the privilege to be visited by Charles Kellman in my clinic in Brazil in 1996, where we did some cases together. I was impressed to see the interest and enthusiasm he displayed for new things. In spite of being a superstar, he was an extremely friendly and thoughtful person. When he saw that I used a dentist chair for my surgeries, he made sure to sit on it and smiling widely, he said, "That's where I had my eureka moment," referring to the inspiration he had when he realized that the ultrasound procedure his dentist was using for tartar removal could be applied to emulsify hard nucleus. That was the beginning of a long story and a great invention. And here we have Kelman's dentist with the inspirational ultrasound handpiece used for tartar removal. So it is fair to say that Phaco was born in a dentist chair. The introduction of viscoelastic agents in cataract surgery was very important to protect corneal endothelium and to deepen the anterior chamber. It added safety to the procedure, especially in cases of low endothelial cell count and in very shallow chambers. The arrival of YAG laser in the early 80s for posterior capsulotomy was much celebrated by the ophthalmic community. However, good for one, bad for others. Very true. The manufacturing of this highly inert autoclavable glass IOL disappeared completely. So this highly inert IOL was gone after the arrival of YAG laser on account of fractures observed in the IOL optic after YAG laser treatment. But the end of the rigid IOL was near anyway with the advent of the foldable lenses in mid-80s. Here we see Thomas Masoko demonstrate his first foldable silicone lens, the Masako Taco lens. This was really a major milestone in cataract surgery, thus boosting the adoption of Phacoemulsification technique. The shift from inpatient to outpatient cataract surgery occurred over a period of few years in the 80s. This society was formed for the purpose of encouraging high standards for this practice. At that time, the number of international members was very limited. Another important milestone in cataract surgery was the introduction of Capsulorhexis in 1985 by these 4 surgeons from 4 different countries with 4 different denominations for the same maneuver. Neuhand's denomination was the one which prevailed. Before 1985, the removal of the anterior capsule was done in this fashion named can opener technique. This award-winning film was presented by Gimbel in the Oscars meeting in Boston in 1985. It shows how the anterior capsule can be continuously torn with a great control in a very elegant fashion. This was a real breakthrough, and I can say I was there to feel the impact. With the adoption of the anterior Capsulorhexis, surgeons took notice of a marked improvement in IOL centration and pupil regularity after cataract surgery. On the flip side, new complications showed up, like the capsular contraction syndrome, the capsular block syndrome, These complications had not been seen before Capsulorhexis, thus ratifying that new techniques bring about new complications. As phaco began to be done in the confines of the capsular bag, nucleus cracking techniques appeared, like Gimbel's divide and conquer. It's still done today by many surgeons due to its simplicity. As we see here. So surgery can be done under great control. The sutureless self-sealing incision with the creation of scleral tunnel and corneal valve had a rather turbulent arrival with the landmark case Pauling versus Singer. In 1991, Singer introduced his self-sealing technique named Frown incision, which became widely used. 2 years later, seeking payments of royalties, Pauling brought Singer to a law court for patient violation of a cataract incision method. This case gained a lot of public attention. With the help of various institutions like the ASCRS, AAO, and many colleagues, Singer successfully defended himself and changed US patent law so that medical methods could no longer be patented. Jack Singer came many times to Brazil, where he had a lot of friends, a lot of good friends, as a matter of fact. In 1992, Fine introduced the clear corner incision, and it quickly became a widely accepted surgical approach. It boosted the adoption of phaco with topical anesthesia. On the other side, an increase in the incidence of endophthalmitis was observed following clear corner incision compared to scleral tunnels. In 1993, Nagahara won the grand prize of the Ascars Film Festival, showing a new way to fracture the nucleus with the advantage of saving ultrasound energy. This technique was coined phaco chop and became very, very popular. And shortly afterwards, several variants of this approach were introduced. The introduction of trypan blue to stain the anterior capsule proved to be very helpful in completing capsulorhexis in case of cataract without red reflex, especially in white cataracts. Scott Burke in 2002 demonstrated that triamcinolone suspension allows visualization of vitreous in the anterior chamber. This is his original ESCRS overall winner film, showing how triamcinolone suspension facilitates vitreous removal in complex cases of traumatic subluxated cataracts, either by limbo or by Barsplan approach. In 2006, Boris Malyugin introduced his ingenious pupillary expansion device, which proved to be very helpful in case of small pupils and stimulated the creation of other devices. A toast to Boris Malyugin for his great invention. My dear cataract mentor Jack Dodek at Manhattan Eye and Ear and Throat Hospital was the first to utilize the laser energy in cataract surgery,
leading me to perform the first human laser cataract surgery in 1990 as published in the Archives of Ophthalmology. Everything happens for a reason, Fernando.
Phantom second laser was introduced in cataract surgery in Europe in 2008, approved by FDA the year after, and was readily commercialized. And here we see the first live phantom second laser assisted cataract surgery performed at the ASCRS meeting in San Diego in 2011. So this was the beginning of a new phase of automation of some steps in cataract surgery. And other types of laser are being introduced in cataract surgery. The reality is the machine is little by little taking the surgeon's place. Not long ago, I asked my dear friend Bob Osher, a highly acclaimed educator and a gifted communicator, to summarize in 40 seconds the most important innovations in cataract surgery in the last 40 years. And this is what he said.
Phaco has just become a very safe, very efficient, very wonderful procedure that instead of having 1%, everyone is using it. That's a big change. I think the second change would be implants. Certainly intraocular lenses have changed. And I think lastly, our ability to hit emmetropia with our increased accuracy of formulas and diagnostics. It's a whole new world. Fernando, we hit the lotto. As cataract surgeons, we do the most wonderful thing in the world. I'm almost 70 and I'm still on the ascending part of my career and loving every day.
Good for you. Keep it up. The good work. Thank you.
And with this cheerful, optimistic message, I conclude this presentation. Thank you all for your kind attention.